Hello everyone, my name is Seung-Hyuk Kim, Professor of Radiology and Urology, Seoul National University Hospital. In this session, I would like to talk on MRI of prostate cancer. These are world maps showing incidence and mortality of prostate cancer. Prostate cancer in Asia and Africa is much lower than the incidence in United States, Europe, and Australia. In my country, Korea, the incidence of prostate cancer is increasing very fast and now in the medium level incidence range with very low mortality level. As you see in these two graphs of Europe and the United States, prostate cancer incidence made its peak in late 1990s and 2000s, and now it is decreasing. But the incidence is increasing quite fast in Asian countries, and it became a very important public health issue in Asian countries. From this chair system, invented in 1967 by Dr. Hiroki Watanabe, a Japanese urologist and the past president of World Federation Ultrasound WFUMB, there has been advancement of transducer shape and function, including Doppler, 3D, elastography, and contrast-enhanced ultrasound. Typical transrectal ultrasound finding of prostate cancer is well-defined hypoechoic lesion in peripheral zone, but the problem is that only 60% of all prostate cancer lesions are hypoechoic and only 20 to 30% of all peripheral hypoechoic lesions are prostate cancers. In other words, this finding of hypoechoic lesion in peripheral zone is neither sensitive nor specific for prostate cancer. Here are two same-looking small hypoechoic lesions in posterior aspect of the prostate. One is prostate cancer and the other is not. We cannot tell which one is which, and always we need a biopsy for diagnosis. In addition to grayscale ultrasound, we can use Doppler ultrasound, elastography, and contrast-enhanced ultrasound to improve sensitivity and specificity of ultrasound in prostate cancer diagnosis. But most important role of transrectal ultrasound is for biopsy guidance rather than diagnosis because of unsatisfactory sensitivity and specificity even with use of these additional ultrasound techniques. I believe you are familiar with journal anatomy of prostate, including peripheral zone, common site for prostate cancer, transition zone, common site for BPH, and central zone and anterior fibromuscular stroma. Anterior fibromuscular stroma is a thin layer of non-glandular structure located anteriorly. This central zone is difficult to identify separately, especially in patients with BPH. Often, transition zone and central zone together is called central gland. So, you should understand the difference of two terms, central zone and central gland. On T1 weighted MRI, these zonal structures are not identified because whole prostate appears as a homogeneous low signal intensity structure similar to pelvic muscles. On T2 weighted MRI, in contrast, we can differentiate peripheral zone and transition zone clearly because of homogeneous high signal intensity of peripheral zone and heterogeneous low signal intensity of BPH nodule. Central zone is not well identified and probably locates along the outer margin of BPH nodule. Probably this thin low signal intensity layer is anterior fibromuscular stroma. This is another case with normal T1 and T2 weighted images, and another case with normal T2 weighted images in axial and coronal planes. In addition to basic T1 and T2 weighted images, we may use other functional pulse sequences. That is why we call it multiparametric or functional MRI. It includes dynamic contrast enhancement that reflects angiogenesis, diffusion-weighted imaging that shows microstructure of the tissue, and MR spectroscopy reflecting metabolism. Among these pulse sequences, nowadays MR spectroscopy is not being used commonly because it is time-consuming and needs special technical support. So basically, T1 and T2 weighted images, diffusion-weighted imaging with ADC map, and dynamic contrast enhancement sequence are included in routine multiparametric MRI. T1 weighted imaging, T2 weighted imaging, we see low signal intensity lesion on left side. Diffusion weighted imaging and ADC map will show the lesion as high intensity and low intensity lesion respectively, and dynamic contrast enhancement shows strongly enhancing lesion in the same location. All these findings will correlate with this pathology map. I mentioned that prostate appears as a homogeneous low signal intensity structure at T1 weighted imaging. However, if MRI is done after biopsy, usually we see high signal intensity hemorrhagic foci at T1 weighted imaging. This article reported that prostate cancer usually locates where there is no bleeding because cancer tissue is harder than normal prostate tissue, and therefore post-biopsy hemorrhage spreads more easily where prostate is not involved by cancer. It means when we are evaluating T2 weighted imaging for prostate cancer, we need to be more careful where post-biopsy hemorrhage is excluded at T1 weighted imaging. If that hemorrhage excluded area has homogeneous low signal intensity at T2 weighted images, that area is certainly an area of prostate cancer. This low signal intensity on left side on T2 weighted imaging is due to hemorrhage and does not indicate cancer area. This sign at T1 weighted imaging is called hemorrhage exclusion sign in this article, and this is a very useful sign in detecting prostate cancer in our daily practice. Here is another case of prostate cancer well shown at all imaging sequences, T1, T2 weighted images, diffusion weighted imaging and ADC map, and the dynamic contrast enhancement sequence. You clearly see hemorrhage exclusion sign on T1 weighted imaging. Here is another case that shows focal prostate cancer lesion at every imaging. Transrectal ultrasound shows focal hypoechoic lesion on left side. T1 weighted MRI clearly shows hemorrhage exclusion sign here, and T2 weighted imaging shows that this area has homogeneous low signal intensity. High signal intensity at diffusion weighted imaging and low signal intensity at ADC map, and focal hyper-enhancing lesion in early phase dynamic contrast enhancement. Let's look at the value of diffusion weighted imaging more closely. Diffusion is thermally induced random motion, and diffusion of water molecules depends on interstitial free water and permeability. In cancer tissue, this diffusion is decreased because of high cell densities and abundant intra- and intercellular membranes. ADC map more specifically represents degree of diffusion, and we should evaluate diffusion-weighted imaging together with ADC map. A case of prostate cancer well demonstrated at T1 and T2 weighted images and diffusion-weighted imaging and ADC map. In this case, diffusion-weighted imaging and ADC map better demonstrate extracapsular extension shown as a nodular protrusion in the posterior margin of the tumor. Diffusion-weighted imaging has many advantages. It needs short scan time and does not need contrast media. It may improve tumor detection and staging and useful in post-treatment follow-up and monitoring of therapeutic effect. Disadvantages of diffusion-weighted imaging include poor spatial resolution and high risk of image distortion. Most important limitation is difficulty in standardizing p-value. Now let's look at the value of dynamic contrast enhancement. Here is a case, T1 weighted image with hemorrhage exclusion sign, low signal intensity of this area at T2 weighted image, high signal intensity at diffusion weighted image, low signal intensity at ADC map. This is dynamic contrast enhancement image of the lesion, clearly showing early enhancement and washout. Here is another enhancing lesion in transition zone due to BPH. Probably you can see the difference of enhancement pattern of these two lesions. This cancer lesion shows rapid washing and washout, but this BPH nodule shows slow enhancement. Pathology map shows left peripheral zone cancer lesion. Another case, T1 and T2 weighted images, diffusion weighted image and ADC map, dynamic contrast enhancement and pathology map. Findings are all well correlated. Here is another case showing value of dynamic contrast enhancement. Transrectal ultrasound showing hypoechoic and slightly hypervascular lesion. T1 weighted image with hemorrhage exclusion sign, homogeneous low signal intensity at T2 weighted image, high signal intensity at diffusion weighted image, and low signal intensity at ADC map. Enhancement and washout of the lesion at dynamic contrast enhancement. If you look at these dynamic contrast enhancement images more carefully, you may see another small, strongly enhancing lesion in the right posterior peripheral zone. If you look back, we can see the lesion in all other MR images. Here is another case of prostate cancer, T2 weighted image, diffusion weighted image, and ADC map. Dynamic contrast enhancement shows abnormal enhancing lesion in the left transition zone. Enhancement curve shows early wash-in and washout of the lesion, and this blue-colored curve represents normal right side. Various quantitative methods of analyzing dynamic contrast enhancement, such as K-trans, KEP, VEP, have been used, but those methods are time-consuming, and so nowadays simpler semi-quantitative methods such as area under curve, wash-in, and washout are used more commonly. This is an AUC, area under curve map, reflecting total amount of flow of contrast, and these are wash-in and wash-out maps that are well correlated to the area of tumor at pathology map. This is a case of prostate cancer in left peripheral zone. You see hypoechoic and hypervascular lesion in left peripheral zone. Dynamic contrast enhancement shows enhancement of not only this left peripheral zone lesion, but also transition zone, but probably you easily see the difference of enhancement pattern of those two areas. As you see in this enhancement curve, this peripheral zone lesion shows rapid wash-in and rapid washout. In contrast, transition zone BPH nodule shows relatively slow wash-in. Here is another case of peripheral zone cancer. The lesion at pathology is quite well demonstrated in transrectal ultrasound, T1, T2 weighted images, and diffusion weighted image with ADC map. If you see dynamic contrast enhanced images together with enhancement curves, probably you easily see the difference of enhancement pattern between cancer area on right peripheral zone and preserved left peripheral zone. Advantages of dynamic contrast enhancement are it shows direct visualization of tumor vascularity, and so it is suitable for monitoring anti-angiogenic treatment. But it has limitations because hyperenhancement itself is not specific for cancer tissue, and there are normally hypervascular tissues, and also there are prostate cancers that are relatively hypovascular. Transition zone is difficult area to detect prostate cancer, and T2-weighted imaging is most important. If there is an ill-defined homogeneous low signal intensity area in transition zone, the lesion is highly suspicious for transition zone cancer, and this finding is called erased charcoal sign. In this case, the lesion is well correlated with the findings of diffusion-weighted imaging, ADC map, and dynamic contrast enhancement. Another condition of prostate cancer we have difficulty is prostate cancer located anteriorly, because the lesion in this area can be easily missed in systematic biopsy. This is an example case. This patient's PSA was continuously high in spite of 2 times of negative previous biopsies, so another biopsy was being considered. Before the 3rd biopsy, MRI was done and it clearly shows an anterior cancer, so the 3rd biopsy was targeted to this area, and prostate cancer of Gleason score 7 was confirmed. These MRI findings are well correlated with this pathology map. Last thing I would like to mention briefly in this talk is PIRAS system. PIRAS stands for Prostate Imaging Reporting and Data System, and now we are using version 2. It is an effective framework for determining the likelihood of clinically significant prostate cancer on multiparametric MRI, and is a valuable communication tool between urologists and uroradiologists. Basically, this system is a 5-grade system in T2-weighted image findings, diffusion-weighted image findings, and overall score. Diffusion-weighted image findings are main determinants in peripheral zone cancer, while T2-weighted image findings are main determinants in transition zone cancer. Peripheral zone cancer diffusion-weighted imaging score 3 will be upgraded to overall score 4 if dynamic contrast enhancement findings is definite, and transition zone cancer T2-weighted image score 3 will be upgraded to overall score 4 if diffusion-weighted image findings is definite. Use of PIRAS system in daily practice needs experience, so every day we refer to detailed system guidelines on the wall of our reading room. I will talk on detail of PIRAS system in a separate session. Summary of this talk is: current multiparametric MRI sequences are T1 and T2 weighted images, diffusion weighted imaging with ADC map, and dynamic contrast enhancement. Each per sequence has its own function and role, and PIRAS version 2 is currently being used.